Good afternoon, everyone. My name is Dr. Tyler Smith. I'm the Associate Dean in the Office of the Learning Environment and Division of Inclusive Excellence here at the University of Missouri, Kansas City School of Medicine. Welcome to the 2025 Dr. Reaner and Mr. Henry Shannon Endowed Lectureship in Minority Health. This lecture is part of the University of Missouri, Kansas City School of Medicine's Dean Lectureship, named and sponsored in honor of the first Associate Dean, then called Minority Affairs, Dr. Reaner Shannon, and her husband, Mr. Henry Shannon. The lectureship was created to promote continued learning and education, as well as bring about awareness about medical issues and health disparities impacting people and communities of color. The lectureship typically occurs on the fourth Friday in February for graduate and medical students, residents, fellows, faculty, staff, and the greater Kansas City community. Dr. Joycelyn Elders, the first African-American Surgeon General in the United States, was the inaugural speaker in 2006. Since that time, the lectureship continues the tradition of hosting dynamic speakers who are local, regional, national, and international leaders in medicine, including UMKC School of Medicine graduates and faculty, members such as Dr. Karen Bacom, Dr. Dana Thompson, Dr. Tim Hickman, Dr. Nevada Lee, Dr. Michael Moncure, Dr. Meena Singh, and Dr. Michael Weaver, as well as leaders in government health agencies and professional medical organizations, such as Dr. Louis Sullivan, Dr. Jane Nadine Gracia, Dr. Alpha Stewart, and Dr. Patrice Harris and Ms. Kiana Thomason. Dr. Reaner Shannon transitioned this life in July 2022, followed 5 months later by her husband of over 60 years, Mr. Henry Shannon, in December 2022. They are survived by their daughter, Ms. Pamela Shannon of Dallas, Texas, and a host of family, friends, colleagues who are present today, either in person or virtually. Ms. Pamela Shannon continues to be actively involved and supportive of the Endowed Lectureship in honor of her parents and to keep the spirit alive of bringing awareness about healthcare disparities and inequities impacting historically marginalized and minoritized populations and resource-limited communities. As my family always says, give people their flowers so they can enjoy them. So Ms. Pamela Shannon. Thank you again so much for your continued support of the lectureship, but also thank you so much for all the years that you shared your parents with us here at UMKC School of Medicine. If you're interested in supporting the Shannon Endowed Lectureship in Minority Health, donations can be made at go.umkc.edu/give. And just a few housekeeping things for those people that are watching virtually. If you're watching virtually, please keep your sound muted so that way we can hear our keynote speaker, Dr. Michael Debaun. We will take questions at the end of the lectureship. For people watching virtually, please place your questions in the chat and we will get to as many questions as time allows. And now, without further ado, I'd like to introduce to you our keynote speaker for the Dr. Reaner and Mr. Henry Shannon Endowed Lectureship in Minority Health, Dr. Michael Debaun. He is the husband of one, the father of two, and the grandfather of three. Please welcome Dr. Debaun.
So first of all, I want to thank the Shannon family and the foresight of those who are not with us to invest in our community. I appreciate the invitation. When I saw the invitation, I was thrilled. I want to thank Pamela for continuing this tradition. I had a wonderful dinner with her and the rest of the team. And Dr. Tyler Smith, who's been almost like a big sister to me, although I'm 30 years older than her, to make sure I made the flight on time and I got picked up, that I didn't walk from point A to point B, and that I'm here. So I really appreciate the hospitality. For those who don't know, I grew up in St. Louis, so anytime I can come back to the state of Missouri, for any reason, I choose to do so. So really appreciate it. So this topic here is academic activism, choosing the right time and the right place. It's the same concept that I have driven home for over 15 years. The beginning starts the same, but the ending is constantly changing as I continue to try to do my part. So I'm going to give you a definition of activism. my experience in medical school, junior faculty, mid-level faculty, midlife crisis, which literally occurred in 2010, and then winter is coming for me since 2023. So activism consists of intentional action to bring about a change in one or more of the following domains: environmental, social, political, and economic. That sounds pretty proper. This was taken from Wikipedia in 2010, but in our home, which I talked a little bit about last night, it's not accepting status quo when you know you should and could do better. So let me just comment on this concept of environmental activism, and it's mitigating toxicity within the environment. As I was having a conversation last night at dinner, it turns out that my experience is clearly not unique. And part of the challenge as a physician is how do you mitigate the toxicity that occurs within an environment? You have to figure out a strategy that keeps you whole. I didn't know that when I started medical school. I left Howard, which, for people who don't know, anybody seen the Black Panther, Howard is more or less like Wakanda, but for 18 to 22-year-olds. And so I had a great time there. In fact, you can imagine leaving Washington, D.C., and then moving to Palo Alto, and when you grow up, your parents, my mother and aunt, looked at the soap operas, and you would always see these people so clean and no problems in the world except who they were dating. And you said, where do these folks live? Who can write a storyline like what you see in the soap operas? And then you go to Palo Alto, and you realize that that's where the storyline starts. On the campus of Stanford is Saks and Neiman Marcus, literally on the campus. You can walk there from your dorm, Stanford Shopping Center. So I was kind of in a shock. But in any case, I was in medical school there, and I made a commitment to help out people who went to Howard for a range of reasons. And so I was on the admissions committee, and I had a chance to review every application of any student that applied for medical school at Howard. And I saw this young man who was there. And this young man, his name was Debaun, and he was interviewed. And during the interview, the reason that he was listed as not wanting to come to, not a good fit at Stanford was because he lacked ambition and desire to travel abroad and learn a second language. And his application was rejected. So what did I know that the interviewer did not know? When my wife and I had picked him up from the airport in Oakland, drove him to Palo Alto. He stayed in our one-bedroom apartment. He received no pre-professional advice in going to medical school at all. He's the first one from his family to finish college and one of the first ones to actually finish high school. He worked full-time to pay for college education while being 100% independent since he was 18. He was a professional musician. And for those who know DC, he played in one of the DC go-go bands as a bass guitarist while he was in school full-time. And despite these obstacles, he scored in the 90-plus percentile in all his basic sciences on the MCAT. So what did I do? I lobbied real hard. I told this story last night. I went to the dean of admissions, and he said, decision is done, rejection letter has been sent out, and there must be an appeal process. I was hard-headed, arrogant, didn't take no for an easy answer. And so I said, well, who's your boss? And he said, well, you'll have to go to the chair of the faculty of senate. And I didn't know anything about hierarchy of medical school. Again, I was young, arrogant, and even ignorant. So I burned a lot of ATP focusing on the unfairness of this admission process, energy. And ultimately, when I left the chair of the faculty senate's office, I was upset. And I said, if he's rejected, then your decision to accept me was a mistake. And at the time, I was a third-year medical student doing extremely well. So ultimately, the end result was Debaun was admitted to medical school. I was thrilled. I mentored him as one medical student can mentor another. He's an outstanding medical student at Stanford. He was one of 2 students nationally to receive a pre-doctoral award to do neurosurgery research. He had multiple first author manuscripts as a medical student at Stanford, and he matched in his #1 choice in neurosurgery and as a neurosurgeon here today. So I had a lot of these interactions, and frankly, they were burning me. Burning me out is not the right word, but I was spending a lot of time fighting these, solo battles of injustice. And I had to ultimately learn through medical school and residency that I needed to change from I will to we will approach. And that's really been the strategy that I've taken. I'm skipping my residency and HEMONC fellowship and second fellowship in the U.S. Public Health Service, which was MP school at Johns Hopkins, and then 3 years of research at the National Cancer Institute. And came back to WashU in 1996. I was the clinical director for the Division of Hematology Oncology. And so this was a very active division of hematology oncology. It was one of the top 10 funded programs in the country. And, so what did I face when I came back? There was no social worker for children with sickle cell disease, despite having social workers for the other diseases, which I'll talk about in a second. There's no camp for children with sickle cell disease, despite having 4 or 5 camps under my umbrella as the clinical director for hematology oncology. I was an oncologist. And one of the life-saving therapies for our children and adults with sickle cell disease is blood transfusion therapy. And the American Red Cross had no blood drives in the African-American community. Why is that important? It turns out that African-Americans' blood better matches other African-Americans. So if 98% of the blood that's being donated doesn't come from people with the same genetic background, you can imagine, as it did happen, many of our children and adults developed antibodies, which wouldn't allow us to transfuse them, which was really a tragedy because literally we would have children and adults die because they couldn't get the right blood to them that matched them. So those last 2 bullets would take another 30 minutes to explain, but we eventually solved both of those last 2 challenges. But I want to talk about something that was near and dear, which is the social worker for this high-risk patient population. So we had brain tumors in our patient population. About 100 children had brain tumors. We had a social worker for them. We had a bone marrow transplant. We had about 25 transplants for our children. We had a social worker dedicated specifically for transplant. We had pediatric cancer, about 200 new diagnoses a year. We had a social worker for those children. Took care of 360 children with sickle cell disease. We had no social worker. So, when I obviously brought this up to leadership, the response was, we will deal with the children with sickle cell disease with an anticipatory guidance. If there's a reaction, we'll deal with it, but we will not support them going forward. So there was no anticipatory guidance, only reaction to the problem. So what did I do? I had this wonderful education from the institutions I just described, and so I wrote a grant. And I wrote a grant to a local foundation, paid for the social worker, didn't call her a social worker, called her a school liaison. But she was a master in social work, had worked at St. Jude Children's Hospital, and she was superb. So what we did with this position, since she was directly working with me, we created a new role. She established a different model of medical social work at the Children's Hospital, anticipatory rather than reactionary. My focus has been, since I've started for a range of reasons, is improve the educational outcome of our students with sickle cell disease. It's often ignored, and quite frankly, it's the only job of a student is to go to school. And as a provider and understanding the challenges of our children in the school district, we really pushed this agenda. So she attended individual education plans for all of our students who were having difficulty in the classroom settings. I made with her home visits. Sometimes you see a child who's troubled, you can't really understand what's going on until you go to the home. And so we made home visits to our families. And then we did come up with a camp for children with sickle cell disease. It was a hope and a prayer for about 9 years. And she became the de facto camp director of this sickle cell camp, where I was the medical director. I stayed there every night. Many of our families, as you know, did not trust the system of going out in rural Missouri and having their kids out there by themselves. So I was there with them. I gave them my assurance. And then my wife and daughter were the arts and craft directors, and the social worker was the camp director. It was all homemade for 10 years, and ultimately the hospital agreed to take it over. So the permanent result of this effort, in fact, the social worker was so well known that people from around the country came to St. Louis Children's Hospital to spend time with her, to have internships with her. She had several presentations at national meetings and was first or second author in several publications. She outshined all the social workers by far. And so they couldn't, when the grant was up, they couldn't fire her because she was literally head and shoulders of even the director. So the end result is she was hired and permanently and absorbed in the budget of the Children's Hospital. And to this day, St. Louis Children's Hospital has a social worker dedicated to this patient population. Now I'm going to fast forward when I was a fellow, and again, highlighting the importance of a teacher and students in the classroom. As a Montessori teacher, the punchline is Montessori teacher was my mother. She called me up and said, son, there's a kid in this class, my student, and if you didn't know anything about Montessori teachers, they track the student's performance individually. So she knew exactly what was going on with this student. And she said, you know, the educational milestones have been lost, and she's doing poorly in class. What's going on? And she peppered me with these 3 questions. And frankly, these have been the questions I've been focused on since 1991. Her name was Michelle, and she said, what is wrong with Michelle? Second question she asked is, what can you do to treat Michelle? And the third question was, what can I do to help teach Michelle? That being my mother saying, how can I help teach Michelle? So at the time that we started this process, silent strokes had not been described in the literature. No one even acknowledged there were silent strokes for a child with sickle cell disease who was doing poorly in the classroom. Their poor classroom performance was attributed to the fact that they were Black, they had a chronic disease, anything but the physiology of the disease. And so over a course of about a decade, we were able to demonstrate that silent strokes were real, that they were progressive, they impaired the cognitive outcome of children and students with sickle cell disease, and there was an opportunity to treat that. It was a long haul. It literally is a decade of pre-trial work to convince my peers that we were on the right track, our team was on the right track. We also conducted a randomized controlled trial, and I'll talk about it in a second. It's published in the New England Journal of Medicine. There's another decade-long effort. We were funded in 2012 and 2002, and ultimately published in NEJM in 2013. Could not have done the work without my colleagues in Missouri, including Jerry here in Mercy Children's Hospital. He and his wife contributed greatly to this effort. There was an international trial. And then just most recently, I was the lead of another international trial. Took us another decade to cure sickle cell disease with the goal specifically to expand the approach to borders outside of the United States. This was published in Blood in 2024. And then just this week, a follow-up to what we had previously done was published in New England Journal of Medicine, evidence in this past weekend for the adult stratum, and the pediatric stratum will be published hopefully by the end of this year. And then what can I do to teach Michelle learn? I have the fortunate opportunity to mentor Allison King as an intern and then resident and then HEMOP fellow, and we talked seriously about opportunities for her to pursue advancement of care for children with sickle cell disease who had cognitive challenges. And so she elected to go on and get a PhD in education and has a strong program, probably the only PhD, MD, who's board certified in pediatric hematology, to understand how the brain is affected by injury and specific personalized strategies to help these students overcome their challenges in the classroom. So this was the trial that I just mentioned, the silent infarct transfusion trial. It's funded from 2003 to 13. The hypothesis was that prophylactic blood transfusion in children with silent cerebral infarcts will result in at least 86% reduction in the proportion of children with clinical evidence strokes or newer progressive silent cerebral infarcts. We had 29 sites, Canada, UK, and France. The imaging core center and the statistical core center was at WashU, and it took us a decade to complete this trial from start to beginning. Here's the end results of a decade. We found that there was a 56% relative risk reduction in progressive strokes in children who were treated with monthly transfusions when compared to children who received no transfusions at all. But the punchline I want to share is this slide here. Understanding the social determinants of health for a range of reasons, we elected to drill down explicitly on the social determinants of health in this population well before it became a popular component of clinical research. So this is what we asked our families to do on $8,500 per person in the household. So family of 3, less than $27,000. And 86% of our families completed this trial when you looked at the patients in total. We asked them to come in monthly for 3 years for transfusions. We asked to get 3 MRIs of the head. And anybody been in a scanner, it's very scary. This was non-sedated. We had 4 neurology evaluations by pediatric neurologists. We literally brought pediatric neurology into hematology because they were saying, no, there's nothing we can do for these children. Why are you asking us to do that? We did 3 cognitive tests in this patient population, 2 quality of life assessments. In this group of 196 children, 169 did everything that we asked them to do. And then additional 9% completed every aspect of the exit interview that allowed us, exit evaluation that allowed them to be valuable. Only 5%, only 9 of 196 children did not do everything that we asked them to do for evaluation. So every time I hear this rhetoric about black folks not wanting to participate in clinical trials, I don't say anything, because if that's your belief, fine. But at the end of the day, here's the data that demonstrates that our folks will participate in clinical trials when you have a staff who's focused on their clinical care, and the families know that, they trust that connection. They know that whether they're in the trial or not in the trial, you're going to do what's best for their child. So none of the children were being introduced to the doctor to participate in a trial for the first time. They were already the providers for those children, and so they understood the trust. And the other component that I want to highlight, race had nothing to do with it. Jerry was the only black man in the whole trial. I couldn't enroll patients because I was biased. So out of all these other 29 sites, there was one other, Baba Anusa, in London. But in the United States, he was the only black man. And yet, we were able to get the endorsement of the mothers and the fathers for them to participate in this trial. So the idea of cultural competence cannot be overstated here in terms of leadership of clinical trials. So I'm bypassing all of this now. I moved past assistant associate professor. Now I'm biostats of pediatrics, biostats, and neurology. And I was still agitated with the status quo, 2007, 2010. So I took a sabbatical. I had a midlife crisis. I was able to go down to the CDC for a year. And while I was there, I started to think, okay, I'm 50, what's the next 15 years of my life going to look like? And I was concerned that I wasn't addressing the real root of the challenge of children and adults with sickle cell disease, which is in Africa. And I asked myself this question: why are we not focused on improving and advancing the healthcare of children with sickle cell disease that live in Africa? And I elected to leave leave WashU and go to Vanderbilt, and I was professor of pediatrics and all these other titles that you see here. And here's the demographics that I was focused on. And here you see really the cartogram of what sickle cell disease looks like in the world. And you can see that the majority of children are actually born in this area that's dark red, referred to as Nigeria. And the NIH didn't have one grant in Africa focused on sickle cell disease. And if you look also at India, again, India has about 40,000 children born with sickle cell disease. And no research had been done in that area at all. And then you look at this compared to the United States, and you can see the contrast of how where the children are born. Roughly about 1,400 children are born with hemoglobin SS, referred to as sickle cell anemia, a year in the United States. If you go to Nigeria, 300,000. So in 2011, I have a buddy named Baba Anusa. Baba had been pulling at my heartstrings to go to Nigeria with him, and then he was going to do a dog and pony show. So what happens when you become an academic professor is people invite you to give talks. And so you give a talk and then you go home. And so I said, sure, I'll go with you to Nigeria, and we'll start off in Abuja. I said, but I have a condition. And the condition is that I'm going to bring my wife and daughter. And we just talked about integrating, work-life balance. I was not going to spend 2 weeks away that summer without my wife and my daughter. And then what I knew for a fact is that I would not remember that trip, but I will remember what I planned at the end of the trip. And the true enough, true form, right now I can't tell you what I said between Abuja and our final destination in Casino, but I do remember the end of the trip like it was literally yesterday. And so I said, at the end of this trip, I want you to help sponsor a camp for girls with sickle cell disease. I said, and my wife and daughter are going to be here. I know they know how to put on a camp. They can work the weekend, and I'll have the weekend off. I can do my other work. So that was the deal. That was the goal. And so Baba agreed, and so we stopped everywhere from Abuja all the way up to Casino. And I probably gave about 4 talk every other day while I was there for 10 days. And I was looking forward to decompressing, getting some work done in my day job, and but that did not come to fruition. So here's the homemade name tags for the girls that were made in Casino. And what I should have known something. And Doris is from Nigeria. She could have told me. She said, you traveling into northern Nigeria doing Boko Haram, was something wrong? Because Boko Haram is literally about 250, 300 miles away from where I was going. And I should have known when the governor escorted us from Abuja up to Casino, and I got a guy with a gun on his in an M16, that something's just not right. So they never told me that we were going to a place where there was some strife. Here's my daughter as we get on. And, as you know, we did things the old-fashioned way, made up the agenda for the camp. In the middle of this, it turns out on Saturday, the parents who had all come in to hang out, they wouldn't leave. So you know how that goes. If you have a retreat or a camp for girls and the parents are there, it's just mucking up the whole system. So my wife came back on Saturday night and says, you got to come to camp tomorrow and take care of the parents, because if you don't, this thing is a disaster. So I had to entertain the parents unscripted for 6 hours while the girls were doing their thing. And in this process, there was a room like this, and men were sitting on one side and women were sitting on the other, and I was teaching them how to take a temperature, how to feel for the spleen. And then a mom in the back of the room said, what should you do about my daughter? I said, what do you mean? She says, well, my daughter is not very good in school. In fact, she stopped going to school, and she walks with a limp, and she's just not very good in the classroom, and she's not very functional at home. Really not very flattering conversation from a mom talking about a daughter to the ears of a pediatrician. So, if you ever believe there's grace, this was one of those situations. Here I am, an expert in sickle cell disease, and I have a mom describing to me a stroke in a child. And so I started to have a conversation with the mom about a stroke. Now, nobody in the room had ever heard of a stroke. And so this turned into a little bit of a tug of war, because the parents wanted me to bring a girl over to the adult side and take her away from where she was having fun. And this is not why I'm here. I'm here to educate you all, not to disrupt the flow for this young girl who's over there having fun. You can see who lost that argument. They brought her back over to this side. They brought her over to this side, so I had to sit down, and Baba's interpreting because they speak Hausa, and most of the folks did not speak any English. And so you can see here the body posture of a young lady who had a stroke, and it was a very challenging discussion, frankly. And it turns out that out of the 42 girls, we made a diagnosis of stroke in 6 of the 42 on that day. And no one knew anything about this at all. So we immediately made a decision the next day to do something about it. And there's no whiteboard for this, right? This is in the middle of northern Nigeria, no ability to do MRI, TCD, no CT scanning, no transfusions, none of that. There was no hematologist in the entire state. They had on the books over 20,000 children and adults with sickle cell disease. So I had to revert back to the clinical science that I was aware of. Can we predict who's going to have a stroke? And the answer is yes. In 1998, this article was published by Bob Adams. And what he did was take a transcranial Doppler, the same kind of machine that you use for ultrasound for a fetus, and they put it up on the side of the brain, and they look at the speed of the velocity of the blood that goes through the middle cerebral artery or the terminal portion of the internal carotid. And if it's above a certain level, it meant that you have about a 10% chance of having a stroke. So this was a major paradigm shift because children, about 11% of the children were having strokes before we started this process. So it's very common for Jerry and I to see, Dr. Woods and I to see children who had a stroke in 1998 and before. As a result of this technology and the implementation of this technology in the United States, the rate of stroke has dropped from 11% to about 1 in 100 to 1 in 10. And so what this study was able to show was that if you give a child a transfusion monthly, you can decrease the rate of stroke by 92% when compared to children who had an abnormal velocity who never received a transfusion. So it's up to a 10-fold decrease in strokes as a result of this therapy. And you can see this young man, this is Alu, he's exactly 30 years my junior. He's one of the mentees. He was a medical officer in Kano, Nigeria at the time that we started this project, and he's doing transcranial Doppler in this child here. So what about the epidemiology? I just need to give you a sense of this so you understand what strokes looks like in this population. On the x-axis is the years of follow-up. On the y-axis is the cumulative number of new neurological events, and these are from the different studies that have been published. I want to point out on the very bottom is the general population of children without sickle cell disease. So if you followed 1,000 children without sickle cell disease, you would expect to have less than one child over 3 years have a stroke. If you followed 1,000 children with sickle cell disease for 3 years, 289 children will have a stroke if they're not treated. And that was the situation in northern Nigeria that I was facing, that we were facing. If they have a normal TCD but a silent cerebral infarct and no strokes, so silent infarct is the work that I was telling you about that we did over the last 20 years, 50 children would have an overt stroke or progression of a silent stroke. So an abnormal TCD and normal transfusions, that's the comparator. Instead of 289, you drop to 227. So clearly the benefit of transfusing a child to get that number from 289 to 27 over 3 years was a main objective of our discussion. However, we are talking about northern Nigeria. And we had a lot of limitations, including the fact that the blood supply was inadequate. The cost of the monthly blood transfusions were beyond reason for that population. And in fact, you could imagine this. If you have been hit by a car and you need a transfusion, not only do they check to see if you can pay for the trauma treatment, but your blood has to be exchanged for somebody else. So in order for you to get a blood, your family has to go out and get somebody to bring that blood in. So it's an exchange program for blood donation. There are unsafe transfusion practices, and there's a high probability of blood-borne infections. So you can see this was not going to be the option for us to prevent strokes in this patient population. So we also had this other challenge, which is extreme poverty. 40% of the population of 83 million Nigerians live on approximately $1 a day. The cost of a CBC is $5. That's the blood count. The cost of the European hydroxyurea produced is 50% to $1 for a 500 milligram capsule. The cost to get the diagnosis of sickle cell disease, that's referred to as the HPLC, after you buy the machine, after you pay for all the people, just the reagents comes out to $8 for a diagnosis of sickle cell disease, which would be standard care in Jerry's old clinic. If we reverted to the point of testing, which is new technology, the cost is $2.80. In one hospital in Kano, referred to as Murtala Muhammad Hospital, there's 20,000 children with sickle cell disease. The children started lining up at 7 o'clock in the morning to be seen at 9. The children are not seen by physicians, they're seen by nurses. These are the nurses. These are literally the nurses that see these children 4 days a week. I refer to them as angels. One of these nurses actually volunteered to work in the clinic for 2 years without pay, because she was so committed to this patient population, and she desperately wanted to work with children with sickle cell disease. They really continue today to be my inspiration. I just came back in January, I'll go back in May. They are truly my inspiration for why I am a physician. They renew me every time I go back. I want to drill down on the economic impact. If you made $365,000 a year, the cost to these families would be equivalent to, for CBC, would be equivalent to $5,000. So we had to come up with a strategy to overcome these barriers. And this is the work that we started since 2011. The first thing we did was write a grant. We got an R21, which is a feasibility trial published in AJH. What we showed was that TCD was feasible in screening as a screening method, and hydroxyurea as a feasible treatment. We taught the entire team how to perform TCD, and then we taught the teachers so that they can teach Nigerians. And the philosophy is Nigerians should teach Nigerians. 88% of the families agreed to screen, and 87% with elevated TCD enrolled in the trial. We then got funded by the NIH based on the feasibility trial to test the efficacy. This is a randomized controlled trial. And we tested low dose versus moderate dose hydroxyurea, 20 milligrams versus 10. And what we showed was that the low dose hydroxyurea was just as efficacious as moderate dose for preventing strokes at a rate that's almost equivalent to that of giving blood. And at the moderate dose, when you give a higher dose, you prevented more children from coming to the hospital. So if the goal is to prevent stroke, you can prevent stroke with a dose that's 10 milligrams per kilogram, which is a very small dose, a dose that in the United States would be considered non-therapeutic. But it was therapeutic for preventing strokes, and I'm sure you could imagine the importance of being able to prevent a stroke in a child for half the cost and no laboratory monitoring. We had philanthropy that was able to support this effort. We screened over 13,000 children with transcranial Doppler in 3 state regions in northern Nigeria, Katsina, Kaduna, and Kano. We identified 883 children with abnormal TCD, and we lobbied real hard to get the states to pay for the hydroxyurea. All 3 states at one point had free hydroxyurea, but as you can imagine, just like in the United States, when there's a change in government, there's a change in policy. And so the current government election was 2 years ago. They still have not put drug back on shelf for this patient population to receive hydroxyurea. I'm optimistic that they will do so, and we're working to, and one of my mentee is actually the governor's new physician. And so we're using all back channels to convince him that this is the right thing to do for the children who live in his state. And we were recently funded for an implementation trial to show that once you strip this process from all the bells and whistles that are required for a clinical trial, that in an implementation trial, we can still have the ongoing benefit of preventing strokes in this high-risk population. So after the trial is gone and the NIH money is gone and the funding is gone, now what? So I just want to show you, highlight some of the strategies that we've undertaken. I've already mentioned that the government that was providing hydroxyurea free of charge, and we intend for them to do this again before the end of this year. I have 4 mentees who advanced their careers as physician scientists. One, Najiba, received a full tuition scholarship at Vanderbilt for her MPH, and she ultimately got a PhD from UAB in epidemiology. She's faculty there now. I have another mentee from Kaduna who received a K-43. For those who don't know, that's a 5-year NIH-funded grant to take the approach that we use in these academic centers into the community health centers. We had Ibrahim Idris received an ASH award to have the largest trial for preventing priapism in men with sickle cell disease using hydroxyurea. We're working with Arthur Burnett, arguably the top expert in priapism and urology in the world. He's a distinguished professor at Johns Hopkins. And we just had this manuscript accepted in Blood with Ibrahim as the first author. And then Lauren was a gastroenterology fellow and now is a faculty member. We just completed a feasibility trial for malnutrition in children over 5. So if you look at the WHO criteria for malnutrition, all the requirements for treatment is for children under 5. But in this population, we were seeing children who had weight for age Z scores that were less than -3. So what does that mean in plain English? That means that they were extremely low weight when you compare them to children of the same age, the same race, and the same sex. We have several children who have a -4 Z-score. That means if you lined up 32,000 children in the world, they would be the last child in regards to weight. So we finished that trial, we published that data, and we're moving forward with another trial to better understand ways to improve nutrition in this patient population. So we have over 40 papers published from 2014 to now, including some of the highlights that you can see here, and now in our 5th trial. Here's the team in panel that was taken in August of 2019, and this is the group that worked so tirelessly to improve the health care of the children and adults with sickle cell disease. And there are 2 Americans, I'm sure you can point us out there. Bud, Dr. Burnett is the gentleman right there. So I'm gonna shift gears here for the next 5-10 minutes and talk about our work in Ghana. Eugenia Vicky Asari is now an adult hematologist. I met her when she was a resident in hematology at Kali Bu Teaching Hospital, the flagship teaching hospital in Ghana. So what's the challenge that I was tapped on the shoulder to address? So in the United States, it turns out that when you look at maternal fetal outcomes, most obstetricians are upset, and rightfully so, as well as women who want to have children, about the high rate of mortality in children, in mothers who are pregnant. And so here's some data that looks at the United States maternal mortality rate based on deaths per 100,000 live births, looking at 26 deaths per 100,000 live births. And you can see in the Northern European countries, there's single-digit numbers, with 3.8 in Finland, Sweden is 4.4. If you look at low middle-income countries, pooled analysis, what you'll see is a death rate for women with sickle cell disease of 4,300 deaths per 100,000 live births. When I started doing this work in Kali Bu Teaching Hospital, the death rate is not a typo. It was 10,000 per 100,000. 10% of the women were dying in 6 months. They usually come in the 2nd or 3rd trimester. So Sam Apong, he was a just starting faculty member, approached me and said, will you help me address this death rate in our pregnant women? And so we set out to do so. And our hypothesis was, again, I had no resources, was that implementing a multidisciplinary obstetric and hematology care team in a low-resource setting would significantly reduce maternal and perinatal mortality rates in a before and after study design. So what do we do? I mean, this is, I learned how to be a good pediatrician, how to be a good doctor when I was at WashU as a resident fellow and chief resident. And so I knew from experience in managing sick kids in the middle of the night that you needed a multidisciplinary care, so we set up this multidisciplinary team. That was literally the first thing we did. We used incentive spirometers, these things that we give the kids after they're in the OR to make sure that they don't develop collapse lung atelectasis. We provided that for them, but as you can imagine, a low-income setting, they can't afford incentive spirometer, so we use a pediatrician trick, which is a balloon. We had the nurses record explicitly how many times they took deep breaths. It had to be latex-free. We maintained fluid balance. We did pulse oximetry. They were not doing pulse oximetry in pregnant women with sickle cell disease, something so routine. Everybody knows now about it because of COVID, but this was not done routinely in the clinic. We set up easy protocols to follow. We gave blood transfusions immediately before and after surgery to prevent acute chest syndrome. And then, probably most importantly, there were now 2 obstetricians that agreed to provide the medical care for the 200 deliveries per year. Because there had to be consistency, and then this group met every Sunday and still meets every Sunday for over a decade. And they're meeting every Sunday because they're busy clinicians working 60, 70 hours a week. And Sunday was the only day that we could guarantee we'd get the majority of folks on the call. So I was very excited. You can imagine when we published this data that we had dropped the death rate by 90%, almost 90%, I was thrilled. turns out that my peers were not in the peer review process, so we didn't get it in the journal we thought we should get it in. And, but nevertheless, the New York Times picked it up, and I was complaining. Probably my last time I complained about a publication. I was saying, I didn't get it into the journal I wanted to get it into. He says, oh, don't worry about it. New York Times has a circulation that's 100,000 times more than the journal you want your publication in. And bottom line is, this work was done in Ghana, and we were able to drop not only the death rate of the mothers, but also the babies. So here's the team here. And as I said, they continue to meet routinely. We've expanded our effort beyond one hospital. Eugenia Isaria, the young lady in the red there, received an NIH award for 5 years to expand this project to another hospital in Accra, Ghana. And then Sam, the young man who approached me early on, is to my far right. He was the head of the Department of Obstetrics and has international recognition for the team that he led that dropped the maternal mortality rate dramatically. And I would be remiss if I didn't point out Lisa. She was the original med tech when I came back to WashU in '96 and has gone on to be a research nurse and a nurse extraordinaire. And it was very important for peer-to-peer interaction for the nurses, for the nurse in St. Louis, Lisa, even though I was at Vanderbilt, to come with me to Ghana because there is a language among nurses. And so she spoke my language, but more importantly, she spoke the nurse language. And so we were able to communicate about what the challenges were, and there was no way the nurse from Ghana was going to tell me what the problems were. But I'll just briefly tell you one, that any time a woman gives birth on the floor, and the average ratio for nurse to patients was anywhere from 20 to 30. One nurse for 20 to 30 patients. When the mother delivered, guess who was her nurse? The same nurse for the mother, for the baby. So that ratio could go up to 30 to 40 easily in a given evening. So it was a very dramatic tell, and we really focused on improving the knowledge of the nurses as part of the team, an underspoken part of this team. And this is the nurse right here who's now going on to get a nurse practitioner equivalent in Ghana. So the last part of this in the next 5 minutes is the American Pediatric Society. I'm happy to report that Dr. Smith is now a member. And so this is the oldest society for pediatrics in North America, honorific society. And I was elected to council in 2018 to 2021, and I was president-elect in 2022. And so as a president-elect, you get a chance to choose the issue of the year. And so I thought real long and hard about what I would pursue, and I had just read Just Mercy. I didn't see the movie, but I did read the book. I can't tell you the book is better than the movie, but I can tell you the book was outstanding. But if you read the book from the lens of a pediatrician, you see something totally different that, with all due respect to Brian Stevenson, he didn't pay attention to. And that's the abuse that occurs in these children, the trauma that occurs while they are held in custody. So I decided that the issue of the year for the American Pediatric Society would be improving healthcare for children held in custody. So I was, you can tell I have kind of a Don Quixote personality, so I didn't know this guy. He's a rock star. I mean, if you don't know, this is the lawyer who has gotten people off of death row and is arguing in front of the Supreme Court about 6 times. And he set up this wonderful facility called the Legacy Museum for Enslavement and to Mass Incarceration. So I went down to Alabama in 2022 and was able to get on his agenda, and we had a very heartwarming conversation. And he told me a lot about the carceral system and challenges that he had, but he had not looked at it from the position of what a pediatrician would look at for children who have been held in custody. So I invited him to be my guest speaker for the American Pediatric Society, and that was a tough task, because this is a guy who is invited to give talks for major graduations across the United States at major speaking fees, and all I had to offer him was a handshake. We were able to bring down the leadership for the council, which included many department chairs for major top 10 universities in the United States, Yale, Stanford, and the like. This has been the first time they've been to the Deep South. I mean, the South where nobody goes to take tours, but the South where people live. And this is the same location Montgomery bus boycott. It's also the same location for those who don't know about it, the Mississippi riverboat fiasco. In fact, his office is less than 200 yards away from the Mississippi riverfront. And here are the members of the council. When we went down there in 2023, we toured the museum. And we also toured the memorial park for lynching, which had specifically all of the blacks who were lynched illegally in every county in the United States. Very important to get the folks on council on the same page that I was trying to get the issue of the year on with them. So what did we do? We wrote an article that was published in Pediatric Research. I am a hematologist. I'm a sickle cell doc. That's all I see now. That's all I've seen for 15 years of children with sickle cell disease. So it was a reach. So fortunately, I reached out to somebody who's an expert. Her name is Elizabeth Barnett, and she's at the UCLA School of Medicine. We wrote this manuscript here. Colin is actually a second-year medical student. He was a gap-year medical student at Howard. He's a gap-year medical student from Howard that worked with me, and then he got into medical school. Holly is now also in medical school, and so we wanted to look at time-sensitive healthcare guidelines for youth with chronic diseases in custody, gaps in care. We wrote additional articles on enhancing medical education, and then there's about 3 other articles. Because of time, I'm just shooting through this. And then the last article was Activism, and this was an interview with Brian Stevenson where we talked about the issues at hand. I want to point out that when we look specifically at the chronic diseases, where an acute exacerbation would be considered an emergency severity index of 2, which means that you should be seen within 20 minutes once you hit the ED room, emergency room. In fact, what happens when you live in an area where you're in a rural hospital, a rural facility, custodial facility, and you're an hour away? Who's going to treat your pain? Who's going to treat your epilepsy? What standard do you have? So I wanted to look for the professional standards within each one of these chronic diseases. And as you can see, there were essentially no guidelines for children who had been held in custody from the professional guidelines for diabetes, asthma, cystic fibrosis, sickle cell disease, epilepsy, and cancer. So I was able to go back to the leadership of the American Society for Hematology and point out this gap in their evidence-based guidelines. We had a committee panel met in DC and wrote the manuscript that essentially now addresses the guidelines that ASH has, American Society for Hematology, for acute medical care for children and adults with sickle cell disease, that was just published a couple of weeks ago. So follow-up, activism, not accepting the status quo when you know you should and could do better. That's what I learned from my mom and dad. That's what I hopefully have passed on to our 2 children, and they will pass it on to their children. And this idea of at some point you want to be less of the I and more of the we, which is so imperative, in my opinion, if you want to have sustainable impact. So I have a ton of folks to thank, and thank you so much again for inviting me here. That's it.
Questions, because we have to be mindful of a class that needs to come in at 1 o'clock.
I have one back here. The question I want to ask you, do you see or foresee the attacks on DEI having an effect on the academic and clinical research into diseases that affect the minority communities?
The short answer is there will be some impact, but I don't think it will be an impact to stop the momentum of the science and the creativity of the people who are committed to this disease and other diseases. There will always be a hard core group of folks who are committed to discovery, and that will happen regardless of politics. It's just like in Ghana, in Nigeria, the team meets on Sundays. They're committed to the population. The nurse who spent 2 years volunteering at the clinic, like she was paid full time. So I believe in that level of commitment to serve others. Yeah.
What's your take on the possibility for scale-up and better implementation of the CRISPR-Cas repairs of sickle cell? In other words, actually gene repair.
Yeah, that's a long answer, but I'm going to give you a very short answer. I'm concerned that medicine and CRISPR-Cas9 and produced by Vertex and Bluebird Bio's therapy is highly pushed by people who make money off of it. It's the therapy that we have provided that was just published in New England Evidence, and the one that we published in Blood, which was the original, and then this is a follow-up, kind of a follow-up, but kind of copycat, validated, if you will. It's a fifth of the cost. It's non-myeloablative, and it can be offered in any transplant unit in the United States where they provide haploidentical transplant protocols. That's not what you're hearing about. New York Times is not going to talk about a therapy that's a fifth of the cost. Non-myeloablative, and most of the adults who try to get myeloablative therapy cannot. It's too toxic. 90% of the adults had a donor with the haploidentical transplant. That's a long-term haploidentical transplant. It refers to a half match. So the 25-year-old adult can have a match from one of his siblings, definitely the mother, typically the father, and if they're married, their child. 90% of the adults can have a transplant. It's a fifth of the cost. So, and it's not as toxic. So it's just that this was driven by academics, not by companies in Wall Street. And so you know less about it. Yes, I think this will be the last one, so I want to respect the timing. Go right ahead.
What are some of the challenges that you met as related to genetic counseling in Africa?
Well, that's a very important point. We established a newborn screening program. Northern Nigeria is Muslim. The head of the Muslim religion in that region is referred to as an emir. He's in charge of $9 million folks who are Muslim. I met with him twice. He was enthusiastic about, I said preconception genetic counseling, called it premarital genetic counseling. Two things have happened. We did our homework after he gave us their blessing. The state passed a law that in order to get married by the imam, you have to be tested for sickle cell trait and receive genetic counseling. We have a newborn screening program at the flagship teaching hospital. Because 1 in 4 individuals have sickle cell trait, we do group sickle cell trait counseling for any woman who is pregnant. And the second part of this, for sickle cell trait, and then for sickle cell disease, we do individual. And so you can have 25, 30 people in the room. So it's working well. And the second part, which is about the sustainability, one of the members of the team decided that she would go to the hospital board and say, we believe that sickle cell testing should be standard care for any baby born in this hospital. So this hospital is the first hospital that I'm aware of in Africa where newborn screening is standard care if you deliver as part of the prenatal package. So I'm very hopeful with education, and really not an American from Nashville telling them what to do, but the people within the country, within the state, making the decision to have regional strategies to improve the care for their children, and they will. I'm optimistic. This is all they're doing. Thank you very much.
Thank you, everyone, for coming. I want to make sure to show a little bit of some blue swag.
Thank you.
I know.
Everybody. Makes sense.
Watch the ozone.
Recording stopped.
Glad you're here.
Yeah, my girl's right now.
I saw you. All right.
We just see you over. Yeah, I was on the zone. Thank you. Did you? No, I was on the zone. Yeah, I was definitely here.